All right, let's get right into it. Welcome to this rapid fire explainer. Today, we're diving straight into Dr. Hagar M. Zayed's curriculum on oral white lesions, and we are going to build the ultimate detail-oriented cheat sheet. Listen, if you're prepping for an exam or just need a rock-solid refresher on oral pathology, you are exactly where you need to be. We're going to break down the buzzwords, the key differentials, and those absolute red flags you need to know to secure top marks. Let's do this. Okay, before we get into the weeds with specific pathologies, let's test your baseline knowledge. When you're staring down a clinical case study, what actually makes a lesion dangerous? What are those exact clinical features that should make you immediately shift your differential diagnosis from, a harmless, benign condition right over to a potentially malignant disorder? Keep that thought in the back of your mind as we go.
Here is your roadmap for this explainer. 1. High-yield malignant risk factors. 2. Mastering leukoplakia variations. 3. Erythroplakia and submucous fibrosis. And 4. Hereditary oral white lesions.
Okay, Section 1. High-yield malignant risk factors. We're starting with the big picture, high-stakes concepts, the predisposing factors that actually trigger these lesions. You absolutely have to memorize this list of predisposing factors. The biggest glaring takeaway here? Tobacco. A staggering 80% of patients with leukoplakia are smokers or use smokeless tobacco. And honestly, the risk depends heavily on the duration and dose. But it doesn't stop there. We also need to watch out for alcohol, which has a really dangerous synergistic effect when combined with smoking. Plus, keep an eye out for viral factors, specifically the human papillomavirus, HPV-16. Other totally testable triggers include nutritional deficiencies like vitamin B12, Plummer-Vinson syndrome, and, believe it or not, even the frequent consumption of spicy foods.
So the absolutely crucial point here is knowing exactly when these lesions turn sinister. If an exam question drops a hint about a mixed red and white lesion or a proliferative verruca surface with some ulceration, man, alarm bells should be ringing in your head from malignant transformation. Some other massive red flags: a lesion that just stubbornly refuses to regress after you remove the suspected cause, or rapidly growing size, loose teeth, unexplained numbness, and lymphadenopathy.
When reviewing the source material, you'll notice a huge emphasis on identifying danger zones. The tongue, the floor of the mouth, and the retromolar area are explicitly highlighted as high-risk anatomical sites. If a clinical vignette places a lesion in any of those 3 spots, prioritize malignancy in your differential immediately.
Moving right along to Section 2, Mastering Leukoplakia Variations. This is the most common potentially malignant disorder you're going to encounter, hands down.
The golden rule for leukoplakia: it's a diagnosis of exclusion. By definition, it's an idiopathic keratosis that simply cannot be characterized as any other disease. Clinically, it typically shows up in men over 50 as a painless white keratotic plaque. But here is the major exam key: it does not disappear when stretched. In fact, it causes a palpable loss of flexibility in the oral mucosa. If it doesn't stretch away, you're looking at leukoplakia.
You need to lock the data from this text into your brain right now. You have to be able to instantly differentiate between these 4 subtypes. Homogeneous leukoplakia is your standard white, corrugated leathery plaque. Speckled or nodular leukoplakia is a mixed red and white patch, and listen, this one has a notoriously high rate of malignant transformation. Then we have verrucous leukoplakia, featuring a papillary or exophytic mass. And finally, proliferative verrucous leukoplakia, which is marked by a very extensive papillary surface.
The text treats these categories like a strict hierarchy of danger, especially speckled leukoplakia. When you see that speckled, mixed red and white description, treat it like a literal stop sign. It means the risk of malignant transformation is incredibly high.
Now, as we study, we need to be super careful not to confuse oral hairy leukoplakia with candidal leukoplakia. They sound similar, but they are totally different beasts. Oral hairy leukoplakia is caused by the Epstein-Barr virus, or EBV, and it happens almost exclusively in patients with severe immunodeficiency. Like 80% of cases are in patients with AIDS. It usually hits the lateral borders of the tongue. Candidoleukoplakia, on the other hand, that's a chronic hyperplastic fungal infection presenting as thick, irregular, leathery plaques. It commonly extends right from the oral commutures on the buccal mucosa. So completely different causes, completely different patient profiles.
All right, shifting gears to Section 3, erythroplakia and submucous fibrosis. We are moving away from the white lesions to focus on some very dangerous red and fibrotic conditions.
let's contrast these two because they love testing this. Erythroplakia is a bright red, velvety patch that mostly affects older males over 60. Most of these lesions are totally asymptomatic, but don't let that fool you. They carry a massive rate of malignant transformation. Now, contrast that with oral submucous fibrosis. This condition is commonly seen in India and Asia and is heavily attributed to the frequent irritation from areca nut chewing or excessive spice consumption. The clinical hallmark here, a total loss of tissue elasticity. It leads to stiff tongue movement and a severe limitation in how wide the patient can open their mouth.
Digging into the textbook definitions here, let's memorize those high-risk locations for erythroplasia. The text explicitly calls out the floor of the mouth, the ventral surface of the tongue, and the soft palate. If you see those specific locations combined with a red, velvety texture in an older male patient, well, it equals erythroplasia until proven otherwise.
Finally, let's hit Section 4, hereditary oral white lesions. This is where pathology buzzwords will absolutely make or break your exam score. Let's conquer the genodermatoses.
First up is white spongy nevus, which is also known as Cannon's disease. It's an autosomal dominant disorder. Intraorally, it presents as bilateral, thick, spongy white plaques, often right on the buccal mucosa. And get this, it can actually be scraped off, leaving a non-hemorrhagic surface underneath. Extraorally, it doesn't just stay in the mouth. It can involve the mucous membranes of the nose, esophagus, genitalia, and rectum. But because it's benign, no treatment is required. Now here is your golden ticket buzzword for white spongy nevus. If a histopathology question describes intracellular edema of the prickle cell layer with prominent cell membranes giving a, quote, basket weave appearance, literally stop reading and select white spongy nevus. Just circle it and move on.
Next is hereditary benign intraepithelial dyskeratosis. A mouthful, I know. Let's just call it HBID. You might also see it referred to as Whitcopp's disease. HBID is critical because of its dual involvement. Orally, it honestly looks a lot like white spongy nevus, but ocularly, it forms these thick, gelatinous, foamy plaques on the conjunctiva, usually within the very first year of life. Patients can develop photophobia and, tragically, even go blind. Because of the severe conjunctivitis, it famously earns the nickname red eye disease.
And here is the pathology buzzword you need for HBID. Under the microscope, dyskeratotic cells are surrounded by adjacent cells, giving what's called a, quote, cell-within-cell or tobacco cells appearance. If you see tobacco cells in a genetics question, and actually it's really important to remember that this has absolutely nothing to do with actual smoking this time, you are looking at HBID for sure.
Our very last condition today is Derrier's disease, also known as follicular keratosis. The source material outlines that its onset is usually in childhood or adolescence. Orally, it produces an overall cobblestone appearance made up of small, whitish papules. But do not forget the extraoral clues. Look out for skin-colored papules that are symmetrically distributed on the face and trunk, a noticeable thickening of the palms and soles, and distinct nail changes, specifically fragility and fissuring.
Let's finish our buzzword checklist strong. If a pathology slide mentions specific benign dyskeratotic cells called corpus rons and grains, where the corpus rons are large, round keratinized cells in the prickle cell layer, and the grains are smaller pycnotic cells in the stratum corneum, well, you have definitively diagnosed Derrier's disease. Boom. Done. Wow, we have covered a massive amount of high-yield pathology today. So I want to leave you with this final diagnostic question to ensure total mastery. Which high-risk features immediately shift your diagnosis from a benign white plaque over to a potentially malignant disorder? Think about it. Review your notes. Recall those highly specific buzzwords we talked about, like speckled lesions, non-healing ulcers on the ventral tongue, and that telltale loss of mucosal flexibility. Master those concepts, and you will absolutely crush the exam. Thanks for joining me on this explainer, and happy studying.